Hello everyone, welcome to another episode of our KLAS podcast. Today we're going to be talking about payer-provider initiative. I'm Lois Croats. Joining me is my colleague and partner in crime, Boyd Stewart. Hi Boyd.
Hey Lois.
How are you doing?
Doing great today.
Yeah, are you excited for our podcast?
This is really good as we celebrate the points of light.
Yes.
And some of the good things happening between health plans and providers.
Definitely. Boyd and I, we are leading the payer-provider initiative here at KLAS, and it's truly an exciting time for us because we are exactly 1 week away from our very first in-person collaboration summit after we took 2 years of break. And so, yeah, this is really good. And we have a couple of industry experts as our guests today, and they're going to be sharing a really cool story of theirs where a provider organization collaborated with their payer and provider partners to expedite the normally arduous prior authorization process. So before we introduce our guest speakers today, I think Boyd, maybe you can give us an overview about our payer-provider initiative and points of light, which our interview will be part of today.
Yeah, so this initiative that KLAS is leading out is really has the focus on getting the patient member at the center and really reducing the friction and challenges that and waste that exists between health plans and providers. And we're doing this by, you mentioned convening. We have the summit coming up, so we're doing some annual convening as well as other meetings. And we're highlighting benchmarking some of the measurements between health plans and providers so that they can know how they do compared to their peers. Mm-hmm. And then the third that you mentioned is what brings us here today is the points of light. And the points of light is a great initiative because we're highlighting successes. We're really trying to show the art of the possible and motivate other health systems to say, hey, maybe these are things that we can adopt and do as well as other health plans.
Mm-hmm. Awesome. Yeah, I think we better get to our guest speakers now. And let me do a quick introduction of them before we welcome them. We have Dr. Cree Gaskin at University of Virginia and Ben Gold with Change Healthcare join us today. Dr. Gaskin trained in radiology at Duke and has practiced at the University of Virginia since 2004, where he is professor and vice chair of clinical operations and informatics, division chief of musculoskeletal imaging, and Associate Chief Medical Information Officer. Phew, definitely a clinical leader of multiple hats. And then Ben Gold is the Senior Director of Product Management for Change Healthcare. He leads clinical data strategy and interoperability for electronic prior authorization and clinical decision support. Ben is the Change Healthcare HL7 Da Vinci Burden Reduction Work Group voting member and participates in the Wendy Electronic Prior Authorization Work Group. Dr. Gaskin, Ben, welcome. We are so excited to have you and share some of your perspective today.
Thank you. Glad to be here.
Yeah, so let's jump right in. I guess maybe we can start with you, Dr. Gaskin. From your perspective, how did this project come about? And what were some of the challenges you were looking to solve with this project?
Well, we were hoping to reduce the burdens that come with prior authorization, but also at the same time improve the utilization of imaging. We had a decision support product that had already been implemented, integrated into our imaging order entry. And we found that it had improved our utilization locally, and we wondered if we might be able to leverage that technology to improve upon the prior authorization process. Clinical decision support at imaging order entry has had a lot of attention lately because of federal requirements, but those pertain to orders for, say, Medicare, Medicaid. And what we were looking to do is apply that same technology, but kind of on the private payer side. So we're hoping to work with the private payer for mutual benefit, reduce the burden on both sides that come with prior authorization, but still expose more orders to decision support, and then potentially expedite our care delivery.
Awesome, awesome. Could either one of you give us a really high-level picture of what the journey has been like? Meaning, how the collaborators work together to achieve this goal, meaning expediting the prior authorization process. Maybe Ben, you can start, and Dr. Gaskin can chime in.
Sure. So like Cree indicated, there's been mass adoption of imaging decision support tools using appropriate use criteria due to the Protecting Access to Medicare Act and their AUC criteria. And to take a step back and get out of the legalese and the sort of legislative ease here, Medicare wanted to try and contain spend for high-cost diagnostic imaging. It's even in the name, it's high cost, right? These studies are not immaterial towards the federal budget. And Medicare basically had one trick in the book. Let's cut reimbursement. And it's been widely known that cutting reimbursement doesn't always decrease utilization, but if you do it just right, you may decrease expense. So this program's thesis was, can we have the best of both worlds? Can we just focus on decreasing utilization where we know there's inappropriateness? And Dr. Schrank at Humana published a 2018 article in JAMA outlining, up to 30% of healthcare is waste. There's tons of academic literature on this subject. And can we do it without having to affect reimbursement for physicians and professional services? So with that backdrop, we have a huge adoption of imaging decision support. And here's the dirty little secret. The American College of Radiology writes this weighty tome, appropriate use criteria, that says, this is appropriate, this is maybe appropriate, this is inappropriate. I'll give you one of the most important ones. Don't order CT for the lumbar spine, low back pain, less than 6 weeks, no red flag. Actually costs us billions of dollars a year. And that's the same criteria that radiology benefits managers use and health plans use. So if you look at how this is structured, we have a tool that's widely adopted. We have health plans, RBMs, and providers all using, for the most part, the same rules of the road. And if, depending on how much into the philosophy of science you are, there might only be one truth of what's the right thing to do here. And that creates a context for providers to say, hey, can we change the rules of the game here? Instead of having to go through that arduous prior auth process, I've adopted this tool. I'm using it for a federal mandate. And the federales believe that we don't need to use prior auth. We use this tool well. What about you? And Dr. Gaskin actually follows in a long line of sort of innovative provider organizations, actually even going back to Mass General Brigham in the early 2000s, who've had this idea of, can we do this? And as much as I like to say this is a technology problem, the hardest part is actually the one Dr. Gaskin solved, which is how do the provider and payers come to the table to solve this problem? So Cree, do you want to take it over from there?
Sure, Ben. So I agree with everything he said. So, we start with societies generating bodies of information on what are the clinical rules. Those are the appropriateness criteria, and those might have been formed over decades. Then there were places like Mass General, as Ben mentioned, that had a locally developed decision support program, which they published on and was shown to be effective. And then vendors enter the space, commercialize a product so it's more accessible to everyone. So, University of Virginia ended up in a scenario where we had a commercially available product that was integrated into imaging order entry. And we approached Aetna and other private payers just for a conversation and just said, we have these tools in place. We have found that it's improved our own utilization locally, just like Mass General had published. They had been successful with doing in their own institution with a homegrown product. And, would you like to partner with us to make this process better? And fortunately, Aetna, which is, one of our higher percentage-based private payers was willing to partner with us. They didn't just enter the agreement lightly. I think they wanted some evidence that it worked. So we provided them some of our data, showed them how we'd improve utilization. And then I think a key point was that we were able to share with them scores that our system had generated on orders that they had already gone through their authorization process. So Evacor is their partner who handles the prior authorizations. And what they found was that all of our orders that received green scores, which is a good score, anything that got a green order, they found that Evacor also authorized. Also in the analysis, they found that sometimes Evacor authorized orders that had received a red or yellow score or lower score in our system. And I think that Aetna gained some confidence that if one of our orders has a green score, it's low risk, meaning that it's very likely to be indicated, and it would be low risk to sort of gold card that and let it go through the system and receive prior authorization from their side.
Hey, Cree, I have two quick questions about that. So for folks who aren't familiar with the stoplights, though I think we kind of can intuit, when you say that yellows and reds were suggested by the CDS and then approved, is there an sort of intuition or insinuation there that the CDS sometimes is more discerning than the RBMs with the utilization management of clinical appropriateness? How do folks interpret, besides, green is green, but also when the AUC or the appropriateness rules suggests maybe or don't do, we're seeing the RBMs come out on the other side? And what might that mean for the payer?
I think it's very complicated. I think that if you say everyone agrees that green is good, so they're authorizing it, our green scores match, I think that those are what I would call low risk. Anytime you have a disagreement, I don't think you can just categorically say one is right or wrong. But I think that from the payer's perspective, if they were to allow a expedite authorization or gold carding of something with a certain score, they just needed to understand that they're not accepting something that was going to go through and that they would have denied it. I think there's some implication that sometimes it could be more discerning, but I don't think that we should make such a clear, bold statement this time without a deep dive.
Sure.
But it's definitely a question that it's a good question, and sometimes it's probably true.
So I have a question.
I'm sorry, one other comment on that.
Please.
One thing with the decision support is at least it because it's electronic and unbiased, it's basically the provider enters their reason for the exam, and the decision support software is going to give the same answer every time in all settings. Whereas if you gave that same reason for exam to different RBMs or even different people working within the RBM, you may get variable responses about whether something is approved or not. And so one advantage there is that at least with decision support, you're going to get the same answer every time in all scenarios if that's the reason that you choose.
And that has to help provider adoption, knowing that, it's the same rules to the game every time you play, rather than these are the rules for Aetna, these are the rules for Medicare, these are the rules for someone else. And I think most ordering docs aren't thinking about, what insurance company do you have, and what's the probability if I pick low back pain versus radiculopathy that you're going to get approved for the diagnostic imaging?
No, this is great. I'm just wondering, you mentioned Dr. Schrank's article, right, where we talk about the enormous amount of waste that exists. Have you guys been able to quantify what has been saved here in the back and forth or the administrative burden through this project?
That's a good question. We did publish a paper where we made some general effort at quantification, but it really was based upon published literature about what is the average amount of time and money spent on an authorization. And then we looked at our number of orders and just multiplied it by that. And so I think the paper that we published where we actually looked at this data was we still had small numbers. And so I can't give you an exact figure, but it would just depend on how much does your institution spend in money and human resources achieving an authorization. On the flip side, how much time and energy are spent by the RBM on managing that, and then multiplying those expenses and costs by how many orders does your institution have.
Yeah, and another way to sort of back into that is providers on average will spend millions to tens of millions of dollars per year on services and technology just to manage prior authorization. Every health system, depending on their size, and UVA is certainly a big health system, will have buildings filled with $15 to $25 an hour workers navigating these portals. Though, Boyd, I think you asked a great question here, which is we found something clinically that makes sense. So physicians are on board. We found something that is common sense for the payer. Why duplicate work when we don't have to? Better patient experience, better provider experience. There's certainly some angles where you could say they might be able to save on their RBM expense in the long run. I think the biggest challenge when we look at these types of collaborations is the financial accounting of this. Can I open up Aetna's balance sheet or income statement and say this program saved blank dollars because of this? And the answer is it's really hard, because if you don't have a medical director do a case review, did they really save $300? I'll leave that to the accounting professors to figure out. But we do know that this is a general, let's say, rate limiter for value-based care, broadly speaking. This is the right thing to do, and people do think it's common sense. And when you get to trying to financially justify common sense, it's shockingly hard. And I don't know why. Well, I know how it's hard. I don't know why it's so hard for us to say the right thing should make sense financially, and here's how it adds up on the ledger.
Mm-hmm. Yeah. Yeah. And from previous conversations that I had with Dr. Gaskin, I think, how we quantify patient experience, how we quantify physician satisfaction, obviously we're making progress there, right? And that's also another outcome to keep in mind. And I particularly enjoyed you guys' comment related to how this is as much of a technology project as a relationship project, because without the willingness to collaborate, without the trust built along the way, I don't think this project would have been as successful. That being said, if you look at prior authorization, it is one of the top administrative burden or arduous process we talked about within the payer-provider relationship, right? And so as KLAS, we're launching pretty soon a deep dive into prior auth technology. So from both of you guys' perspective, what something related to you guys are doing with CareSelect with your payer partner, how's this approach is a little bit unique for the market, and just for any organizations who might be looking to accomplish what you guys want to accomplish. Any comments there?
Oh man, I could fill up like 3 more podcasts on that. Cree, it sounded like you want to say something.
Yeah.
Well, I think it partly answers this question, but I don't really feel like I completely finished answering an earlier question about how we got it to work. So I'd like to just at least finish describing how the partnership got it to work. And I think your point is well taken that that the collaboration was key. And so I'd like to talk about the rest of the collaboration. So, after Aetna looked at our data, they agreed in concept that we could do this, and they asked their RBM Evacor, could you guys work with this? And so we all got together on serial phone calls monthly and had working calls to work through this. And Evacor agreed to modify their intake website in response to the request. And so what happens is when our site logs in based on our tax ID, eviCore recognizes that it's UVA and it's going to follow a certain rule set. And so the first question that gets posed is, did this get a green score? And so if it gets a green score, they don't ask all the questions. It jumps forward to the end. So the submission is shorter and there's an automatic authorization. So what that allows us to do is when we get an order that has a green score, we know it's going to receive an automatic authorization when we go through the submission process. So that allows us to schedule same day or next day or whatever, whenever there's an appointment that's next available and is convenient to the patient. But it really did take all the parties working together to get it to work.
Yeah, and to build off that, is this is this a one-of-a-kind thing? Can we see more of what Dr. Gaskin did at UVA, and what's the market doing? So I would say what's uncommon about what Dr. Gaskin did is there's not a lot of service lines where there's a federal mandate that requires clinical decision support tools that look really, really similar to prior authorization. So on one hand, we could see this use case done for med-surg, for whatever. There's actually a fair amount of legislation that's sort of inching towards parts of this conceptually with CMS 9123, or sorry, the House bill, which was shelved last year. So that's the one thing that's a little unique. What we're seeing here with imaging is unique to imaging. But because of that mandate, it's actually highly repeatable. And I think one of the challenges or one of the opportunities for providers and payers is for most providers, and actually most payers, and I'll take Aetna and Virginia for a minute. I know that all of their major in-network integrated delivery networks are using CDS tools. They may be using mine. They probably are. So what that means is that the provider organization, the payer organization have this sort of big picture conversation that could happen. And this is where it's all about relationships. If Cree and his merry band of radiologists in the state of Virginia got together and approached Aetna, Aetna would look at this project a little differently, as instead of being maybe a one-off request, a more holistic program. So that theme of providers working together to approach the payers and also collaborating with the payers means that what Dr. Gaskin did here is not an anomaly, right? When you look in 2004 when MGB did this, this was homebrew. They built their own technology, their own AUC. Now we're talking about commercially available things. This is democratized. Anyone can do this. And it's really about those relationships, providers with other providers, but especially provider with payer. When you get outside the imaging space where we have this sort of uncommon federal mandate, the market gets a lot more interesting. There's a lot of different theories on how prior authorization is going to be solved. And I'll try and keep this very brief. There's basically two prevailing theories. We've got an arduous process, and we are going to use machine learning and our robotic process automation, aka bots, which, by the way, for the record, have been around for a while. And we are just going to make this crappy process faster. And by the way, there's a ton of money in that. That is not a bad solution. But where Cree talked about web forms and logins and questions, this is all about trying to get bots to take those $15 to $25 an hour workers and make the same clicks they would. And it's an arbitrage game. Can I take that worker and can I automate 80% of their clicks? I'm not sure. The answer is it's really, really hard. And then there's a second small group of folks who are saying, what if we go from medical necessity out? What if we try and automate these medical necessity rules and build off of the type of pilot that we see, or actually the sort of growing group of providers with imaging AUC? And that's the sort of Change Healthcare point of view, which is, there are only two major creators of utilization management rules in the country. One of them is Interqual, which is Change Healthcare's asset. It's actually my sister business. So our point of view when we look towards prior auth in the future is the template that we used for auth for imaging decision support without a federal mandate is going to be the way forward. And that's really getting to deep technical automation, making it easy for everyone. It's a hard technical problem, but we think it's going to create the most value. And you see those types of technical themes embodied in the Da Vinci work groups and how they're structuring, CRD, coverage requirements, discovery, DTR, documentation, templates and rules, and prior auth submission paths. So that's my very short version of the market. scan and sort of how folks are aligning and sort of where change is positioning itself with those market trends, building off of the CareSelect platform and the type of work our luminary partners like Dr. Gaskin does.
Great, great. I think this is very, very valuable suggestions and advice for healthcare organizations looking to do something similar. And well, time flies when we are having fun. I think our time is almost up. I wish we definitely had more time to discuss this. Or like Ben mentioned, we have 2 more podcasts scheduled to talk about this. But do you guys have any closing thoughts around this project that we haven't touched upon?
Sure. I think to the last question, is this a one-off or repeatable? It could be easily repeated. This software is available widely, and everyone's got the same prior authorization process, so it could easily be reproduced in other sites. And then maybe I just comment on what I haven't had a chance to share is some of the outcomes that we've experienced. Our providers are really excited about the program because they know when they have an order that's green, there's no risk of peer-to-peer review. So we have definitely high provider satisfaction out of this program, which we've been running for several years. At the same time, we've been exposing more providers and orders to decision support than they would normally be exposed, because this program is being applied to a private payer scenario, which we're not obligated to do. We're doing for this expedited prior authorization program. We've been scheduling earlier, so we're getting MRIs and CT scans done 2 to 3 days earlier, sometimes even same day. We're filling slots, which normally would have been missed because they would have had to wait a few days for prior authorization to be completed. And our submission staff are submitting and getting authorizations with less work. So a lot of positive outcomes we've experienced locally, and I certainly hope this can propagate.
Yeah, my sort of takeaway for the folks listening to this is for imaging decision support, you can start now. Now is the time to do it. There are no longer technology barriers. It's just the question of you picking up the phone and talking to your payer, and consequently your payer picking up the phone and talking to your provider. It's all about collaboration and relationship. I think in areas outside imaging, there's still a lot of technical kinks to work out, but as a vendor who builds widgets to solve these problems, the future is very promising, and we're moving much faster than I thought we would sometimes. So I think there's a lot more to be done in this space.
That's excellent. Well, thank you so much for your time as well as this great effort. I just want to reiterate, as we went on this journey for Points of Light, it's a hard criteria because I think you mentioned this, Ben, is there's some of these paths where we're just paving the inefficient path, which isn't always a bad proposition, but when we can pave new paths and more efficient paths, I think patients win, physicians win, and healthcare wins, as well as the health plans. Everyone wins. And so when we did these Points of Light, the criteria is we have to talk to the 3 parties involved. That's the vendor partner, the health plan, as well as the health system. And as we interview them, they all have to agree that this is a win for their organization. And so we, of all the submissions, we had many that didn't fit all those criteria, as either the health plan or the provider said, no, I think they're doing this to us, not with us. And as you do this with your health plan, we want to congratulate you guys on winning that Point of Light among 13 others, but there was only 14 awarded this year. So congratulations to Change Healthcare and University of Virginia, as well as Aetna on this project.
Yeah, we really appreciate your hard work and innovation. And Boyd, I look forward to doing more Points of Light success stories like this. Yeah.
Well, hopefully we get these repeats, right? Where people just check this off, and this is something that scales across not only University of Virginia and Aetna and the other commercial plans, but just across U.S. healthcare. So thank you.
Yeah, thanks so much for joining us today. And for our listeners, if you have any questions or suggestions over our payer provider initiative, and feel free to go to our website or leave us a message on our email. Thank you.
Thank you.